confirm that you can see my slides?
Yes.
Fantastic. Okay, so my name is Marumbo Mtegha. I'm a pediatric hepatology consultant based in the UK in Leeds, and I'm going to give a talk about acute hepatitis of an origin that's sweeping the nation right now in the UK. So first of all, thank you to Demos and the organizing committee for inviting me to speak. It's an honor. And I've got no conflicts of interest in this talk. And the data I'm presenting to you today is taken from the UK Health Security Agency. We've had 3 meetings so far since the start of this mini crisis, so to speak. And this is data from the last meeting. We'll do another one next week. So I can tell you informally, I can annotate the figures informally as we go along, but so the figures I'll present are from May the 16th. So by way of introduction, if anybody is uncertain, there are 3 liver centers for children in the UK, and they're all transplant centers. As you may or may not be aware, liver services in the UK have been completely separated from gastroenterology. So there's only 3 liver centers, and this effectively splits up the country in geographic regions, South, Midlands, and the North. And I work at Leeds General Infirmary here in the North. Just a bit of background. It's always nice to give a bit of history. Our liver unit was founded in 1994 by this lovely lady here called Dr. Patricia McLean, who's since retired. We did our first transplant in the year 2000. We've performed over 400 transplants, and we transplanted around a rate of 20 to 25 a year. Just the information about the team at large, essentially 4 physicians, 4 transplant surgeons, and the rest of a multidisciplinary team, as you might expect in a transplant center. And to demonstrate that we cover essentially the entire north of England and parts of Scotland. Not pictured here is Northern Ireland and even mainland Ireland, where we take referrals from. And due to the geographical distances involved, you can imagine we travel out to the nearby cities, because you can imagine for these families traveling all the way to Leeds for 50, 60-mile trips, it's much more convenient. And we share a ward with the paediatric nephrologists in Leeds. So that's a bit about who we are. Now let's get on to the topic of this acute hepatitis. Now, before I go into the crisis, it's important to understand the background to all this. So with acute hepatitis, as you can imagine, any child presenting with a gastrointestinal illness, a viral infection, sepsis, various drug reactions, is highly likely to have raised transaminase levels and may or may not be jaundice. And that's quite common. And in the liver center, we frequently get calls, or the juniors get calls about many of these kind of cases, but we won't see 90% of these referrals. A lot of them will be able to investigate, manage in the local community, and they won't make their way over to us in the liver center. What actually makes its way into the liver centers are the children with severe injury and essentially termed as an acute liver failure. So that's any child with a very high transaminases. We're talking sort of over 500 in the thousands, with an abnormal INR. So the definition of liver failure say essentially if you have an INR over 1.5 with encephalopathy, you have liver failure. Without encephalopathy, an INR over 2. And these are the patients that we will admit in Leeds. It's important to note that in almost half of these kids, we never actually find a cause. So once you've ruled out infectious causes, metabolic causes, poisoning, etc., almost half of them, 40% of them, we will never find a cause. And that's what we term non-ATE hepatitis, literally meaning non-hepatitis A, B, C, and E. And we'll see about anywhere between 8 to 13 cases a year. That's in Leeds. And a few of them will be very severe and move on to require a transplant. And we do about 2 or 4 per year. Interestingly enough, 20% of these children, whether they're transplanted or not, end up getting an aplastic anemia. That is, drop in platelets, drop in hemoglobin, and we end up sending them over to the hematology teams. And sometimes in extreme cases, they end up having a bone marrow transplant. So even though we haven't actually found a cause for these non-AT hepatitis, the current theory is that this is all immune mediated, and because the fact that they move on to have an aplastic anemia. And in our center in Leeds, we've given a few of them steroids as well, with some success, although it's a bit controversial if you speak to other liver centers, because the question is, would these children have recovered or not if we hadn't given them steroids? But it's something that we do in Leeds. So what happens when the child with an acute liver failure comes into us? essentially there's nothing we can do because, if we don't know what's wrong with them, essentially we support them with, maintaining normal glycemia, IV fluids, NG feeds, broad spectrum antifungal antibiotic cover, manage any secondary complications such as ascites, and you observe them neurologically. Because essentially with liver failure, what we're very good at doing is predicting who is going to die or who's going to have a terrible outcome. So that's usually, for those who are interested, if your INR goes way above 3 or 4, your bilirubin's above 300, we know in those circumstances that a child must be put on the super urgent transplant list, or else they have a 90% chance of mortality. So the question then becomes, if we hadn't transplanted them, would we have recovered? Hard to tell, because they may or may, nobody waits that long because the risk of mortality is so high. So that's the background to the acute hepatitis. The question is, what changed? Why have we got this sudden rise in cases, and what are the factors? Before we go into it, this is more, it's very interesting to look at certain other diagnoses. So certainly, for example, when it comes to other common conditions. Now, the pandemic hit, and what I'm going to describe now are trends. Is it coincidence? Are the factors all related? But if we take, for example, a condition called biliary atresia, which is the commonest cause for liver transplantation in the West, essentially, and we normally diagnose these at the rate of 50 cases per year. Now, what happened in the UK was everybody went into lockdown. And what we noticed in the liver centers is that in a 6-month period, we only diagnosed 8. So this led to this fear that were all these children in the community undiagnosed, going to suddenly land on our doorstep, all needing transplants. But that wasn't the case. And later on, we spoke to our European colleagues, and they've also reported similar kind of drop rates, which really lent to the theory that all these mothers who were essentially at home, not interacting, were suddenly not exposed to this environmental trigger that caused biliary atresia. So that was the first thing in terms of thinking, what kind of effects must the pandemic be having on general health? Then we moved on to another common condition in liver centers called autoimmune hepatitis. So essentially, just like with type 1 diabetes, you get immune-mediated injury of your liver, which is frequently diagnosed in adolescents and teenagers with no known real cause. But if you look, interestingly enough, the years prior to the pandemic, and just during the pandemic and the year following that, our diagnosis rate doubled. So the question again is, has this been something that because children were isolated, lacking an environmental trigger, and what became of their immune systems once they were suddenly released back into the wild and interacting with other patients? And then more closely related to the topic at hand this evening, I mentioned earlier about aplastic anemia occurring in association with non-AT hepatitis. What we saw in our center was that in 2021, we saw 8 cases of children who had a predominantly hematological picture with liver injury, but none of these went to transplant, but they had quite a severe hepatitis that resolved very quickly. And ordinarily, we'd ordinarily see that pattern in about 1 or 2 patients a year. We saw 8. So clearly, during the pandemic, there's been this effect on, how people's immune, host responses, susceptible, and the changing of individual susceptibility. And could that be because people had been exposed to COVID-19, the virus itself? Had the lack of exposure from lockdowns made people more susceptible, altered their immune systems? Somebody says, idle thumbs, idle hands, and idle immune system is more likely to attack itself once it's exposed to a real pathogen. So the real question that the 3 liver centers that we asked ourselves were, is this new hepatitis the latest manifestation in this phenomenon of pandemic, isolation, and co-infection? So essentially, coming to the acute hepatitis of unknown origin, this really began in sort of late last year, really in significant numbers in January of this year. What we started seeing across the 3 centers is that the number of calls we were getting about children with really high transaminases and coagulopathy was unprecedented. And there was a high rate of acute liver failure. So children requiring admission to our unit. And as such, when we all reported that, the UK Health Security Agency leapt into action and started essentially a process of massive data collection, serological investigations, both in the centers and in the local hospitals. And a lot of demographic data was obtained to try and see, was there a pattern in individuals? Was there anything to sort of tie all these cases together? And once this happened as well, the 3 liver centers on a weekly basis would meet and discuss, share, exchange information on the kind of cases we're getting, what we were seeing. So so in England, Wales, and Northern Ireland, Scotland has a different definition for some unexplained reason, but essentially it's any child under the age of 10 with an ALT transaminase levels of over 500, which is actually a very broad category when you think about it. And it does capture a lot of other reasons. So if somebody had, one of these hepatitis for a known viremia, at least in the initial period, they'll be investigated as one of these children with acute hepatitis of unknown origin. So the data I'll present shows that as of May 16th, we had 197 cases. I can tell you that we had about 222. So that number has gone up when we last met last week. And essentially what we're seeing is that aside from them taking a longer time to recover, they're not behaving very differently to what we call the classic or old autoimmune, non-AT hepatitis. So they all come in, they all have similar problems with hypoglycemia, coagulopathy, ascites, and a few of them have gone on to require transplant. So in our center ourselves, we've transplanted about 4. In total in the UK, it's come to about 14 or 15 transplants. So out of about 220. So it's been really hard to unpick, are these children that were non-AT hepatitis that were going to be transplanted anyway? And which are the ones that are the true sort of non-AT of unknown origin? But the common thing that we find with all of them is that they all start their illness with a gastrointestinal symptom. So the typical story is a toddler, and it says under 10, but they're all really under 6 years of age. And they all present essentially with diarrhea, vomiting of a short duration, and the parents usually bring them to hospital because they've turned yellow and jaundiced. And this is a slide essentially to demonstrate that the 197 cases with a really high hospitalization rates, thankfully, none of them have perished. And essentially, most of them are discharged. But the thing is that they do take a good while to resolve, over a month, for their symptoms to resolve and for them to be finally cleared. Interestingly enough, what we have discovered is that adenovirus has become the most detected pathogen. So of the 170 cases that were tested, we have a 68% positivity rate. And that's mostly from sampling of the blood. All the children are supposed to have fecal sampling as well as respiratory sampling. And because this data is incomplete across the different hospitals, so that number may actually be lower, but adenovirus has been the main culprit. We've been very hesitant to say this is definitely due to adenovirus because, interestingly enough, in that classic non-AT hepatitis group that we've seen, we used to get about 20 or 30% were positive for adenovirus, and we always assumed they were a bystander. And if you're talking to sort of most people, most hepatologists in liver centers, the level of the viremia was always very low, sort of 800 to maybe 10,000 copies, and what we consider significant is something like in millions of copies. So we never really thought that this was causative for acute hepatitis, but clearly with these ones of unknown origin, it's something we have to take into consideration, that this either maybe not a direct effect, but playing as a cofactor in causing this syndrome. As you can imagine, we've tested for several different viruses. SARS-CoV-2 has been another one that's been detected in a few cases with available results. So this is adding to the complexity of what's the actual cause of this hepatitis. And we've also detected adenovirus-associated virus, which, if I'm honest, I only discovered or heard about when we're talking to the public health people who typed the difference adenovirus, and the differences in terms of, well, I didn't know, but for anybody else that didn't know, essentially to do with it's similar to adenovirus, except that it's got a less of a DNA burden and slightly less virulent. So just by way of illustration, you can see that adenovirus by far tops the other pathogens. So HHV6, EBV, enterovirus, CMV, RSV have all been detected, but many other ones haven't been detected as well. So this was pretty much the thing that became fairly clear very early on, that these children had a high rate of adenovirus. What is interesting is that they all presented with a gastrointestinal illness, but not all of them were positive for adenovirus in their stool cultures as well. Just to see, remember I mentioned about how the extensive family questionnaires went out to see if there was a difference in the terms of families. In the first 60 patients that were enrolled in the investigation, no difference was found in terms of where they traveled, where they'd been exposed to, occupation, diet, nothing. They couldn't find a pattern to what may be causing this outside of the adenovirus. And the subsequent 70 patients, for a brief while, they thought they were onto something because they reported a high contact with pet dogs, but even then, nothing came of that in the end after checking the dogs and checking the different types of adenoviruses. That ended up being a red herring. So as of today, we're still unsure as to exactly what it is that's linking all these cases together. So now you may be asking, what do you do for these kids when they come into hospital? Not much different from what we normally do from a child with acute liver failure. Supportively manage them. As you may know, cidofovir is an antiviral agent that is very effective against adenovirus. And we've been very reluctant to use cidofovir in some of the children, namely because cidofovir has to be given as an infusion. It requires a huge amount of IV fluids prior, and a lot of these children come in with ascites already and some degree of renal function, and cidofovir is nephrotoxic. So on balance, most of us have been hesitant to give it for all the children, especially since they don't seem to be, there hasn't been any proven benefit. Anecdotally, from my colleagues working in other centers, they've said, who've used it, they've said it doesn't appear to have made a difference in terms of how long they stay in hospital. Even though the viral counts drop, it doesn't seem to make a difference. We only gave it to one of our patients who needed a transplant because she had a encephalitis, a proven encephalitis infection with adenovirus in her CSF. So we ended up giving her some cidofovir. Again, her count, but she remains unfortunately in a bad state. So what are the current working hypotheses? Is it that we have a normal adenovirus infection combined with an abnormal host response? Very simple. Is it because we have a normal adenovirus infection, but actually because of lack of exposure due to isolation of all these children, that we're now having a much more severe response to the adenovirus infection? Is it that there's a massive epidemic of adenovirus in the community of a new particular strain that's causing this under-recognized complication? More likely, we think, are these related to abnormal host responses. So for example, is it the fact that these children have been exposed to COVID-19 or some other infection, and then they've been primed to therefore get this reaction when they're infected with adenovirus? Is it that there's a co-infection with an as yet unknown pathogen with SARS-CoV-19 and adenovirus, the combination of all three? Is it that they have an abnormal response to an environmental exposure because they were isolated, they didn't get exposed? Another, they're back in school interacting. It's a combination of all these things again. Or are we dealing with a completely new form of adenovirus? Now, we've been told it's a rarer form, it's a rarer genotype of adenovirus, but not one that hasn't been seen before. So that's sort of poured cold water over that theory. And finally, more broadly, are we dealing with some sort of post-COVID-19 infectious syndrome or some new environmental exposure we know of, or a completely new infection that's been undetected so far, or worse yet, a new variant of COVID-19? The latest we've seen so far is that it appears to be slowing down. The number of referrals we're getting has massively dropped. We only had 5 referrals last week. We still have 3 patients in hospital, 2 of which have received transplants, unfortunately, and 1 is recovering, having been in hospital for about 2 weeks. And we've advised the local pediatricians to keep an eye on their blood counts because, again, this has only been a few months, and we know the risk for aplastic anemia can happen within the first year. So we're advising that all these children get followed up from a hematology perspective. And hopefully, we're seeing the end of the trend. And that's pretty much it for my talk. You're more than welcome to come to Leeds and join us at any stage, and I'm open to hear your questions. Thank you.
Well, thanks for this excellent talk, and thanks for keeping it short. Any questions? Please. Όποιος θέλει να ανοίξει το μικρόφωνο και ζητήσει απευθείας. So if anybody else is not ready to ask a question, can I ask, what's your gut feeling? What do you think is the most likely explanation for the pathology and pathophysiology of this condition? You told us about the working hypothesis, but what's your favorite one?
My gut feeling is the combination. It's the combination of all three: idle immune systems, lack of exposure, and abnormal host responses. It's hard to prove at the moment. It's going to be tricky, but that's given the trends we've seen in the other conditions I outlined before. I think that's the most likely. That's the most likely hypothesis.
And one question from the chat. You get pyrexia in these children? Are they feverish?
Can I ask something?
Yes, they all present initially with pyrexia at home. It usually resolves by the time they get into hospital, but the most common presentation is a gastrointestinal illness with fever. They get jaundice, and that's what takes them to hospital.
Okay. Can I ask something?
Of course.
Thank you for your excellent talk, and thank you for so many data you've presented to us. I would like to ask, well, I understand that in your center, the referrals are from for the, let's say, not light cases, okay? But do you have any idea how many of these children referred to you have been biopsied? Have they performed biopsies in all of them?
Oh yes, well, it varies from center to center. So we haven't. The trouble with liver biopsies in the acute settings that they're not very informative. So when these children come to us, they've got coagulopathy, so it's unsafe to biopsy them because they'll bleed. And in the past, historically, if you biopsy children who have been acute liver failure, you see the same thing. It's all just a necrotic liver. They're not really diagnostic. We've biopsied the ones who we've given steroids to and they recovered. And that's purely because we give them an agent like steroids, we have a responsibility to follow them up. So we've biopsied them sort of a month, 2 months down the line, once they recovered from the illness and they no longer have coagulopathy. And so far, nothing diagnostic, but we're talking small numbers. I think we've only biopsied about 4. I'm not entirely sure what my colleagues in the other centers have done, but the biopsies that so far have been uninformative, but we don't do them acutely when they come in because they're just too coagulopathic. And
do you have any idea about histopathological findings that they have done biopsies? And the histological findings in the biopsies?
Oh, it's very non-specific. Essentially, a recovering hepatitis. So, recovering both portal and lobular inflammation, just recovering. Nothing to suggest it's immune. Like there's no predominance of plasma cells or anything like that. So far, it's been non-specific.
Okay, thank you.
Χριστίνα ρώτησε. Άνοιξε το μικρόφωνο σου και ρώτησε. Χριστίνα, δεν σε ακούμε. Πρέπει να κάνεις unmute.
Sorry. Okay, now? Okay, yes. Thank you. I would like to ask, since all these children present with gastrointestinal symptoms, if a child has vomiting and diarrhea and maybe a fever, should we perform lab tests? When should we perform lab tests? Or should we wait for them to become jaundiced?
I think you've touched on a very important question, because a lot of these children, the reason why they went to hospital was because they became jaundiced. Because you're right, ordinarily a child presenting with gastrointestinal illness, if they're not jaundiced, they'll just be advised to fluids, etc., go home. So they all pretty much are presented with jaundice, which is how we've picked them up.
So jaundice is a prerequisite to make the diagnosis. Did you see any cases that children were not jaundiced yet, although they had hepatitis?
No, interesting question. We haven't seen, no, you're right. They're all jaundiced, actually. We haven't seen any without jaundice. They're all jaundiced to a certain degree.
Okay, because all parents come to us and are very worried about this condition, and they ask for lab exams, right, which we regularly deny them because they're not jaundiced. So we could say that we're safe to skip the tests unless a child develops signs of jaundice. Is it safe to say to take this as a rule?
I would say that's a very practical approach, because the reason why I'm hesitant to fully endorse that view is because you remember when I showed you the definition, we haven't actually included bilirubin in that definition. It's based on the transaminases. In practice, yes, I would say that if you're not jaundiced, chances are you'll be okay, because if you look at the severity markers of acute liver failure, bilirubin forms a part of that. So it's very rare to see a child in full-on failure without jaundice. And yes, I suppose from your perspective, from a practical viewpoint, you can probably employ
because
that.
We're mostly in primary care, and we have to screen the children that are candidates for a severe disease. Of course, we're going to do lab tests if a child is severely unwell, but we have to separate for the greater number of children, the ones that have to be tested or not. Thank you.
That's a good approach. That's a good approach.
Άλλες ερωτήσεις? So Marumbo, thank you. I think there are no more questions. It was a lot enlightening. Can I kindly ask anybody, all of us, to turn on our camera so we can take a picture and then say goodnight for everybody. Sorry for being so late. Να ανοίξουμε λίγο τις κάμερες για να καταγραφούμε όλοι, έτσι για το καλό. Να είμαστε γεροί να βρισκόμαστε. Ελπίζω να ήταν χρήσιμο σε όλους. Νομίζω ότι καταλάβατε ότι πρόκειται για εξαιρετικό ομιλητή και ελπίζω σύντομα να βρεθούμε από κοντά. Φτάσαμε από την Κύπρο μέχρι πολύ βόρεια στην Ελλάδα και ίσως και βορειότερα κάποιοι. Marumbo, thanks for the excellent talk, and we hope next time you deliver another excellent talk in Greece rather than via internet. Okay.
It'll be my pleasure. Thank you very much.
Best wishes to your child. Καλό βράδυ. Ευχαριστούμε όλους.
Αυτό ήταν.
Καλό βράδυ.